Welcome back. This is part 2 of Chapter 57's lecture of female disorders. And we left off after my little technical difficulty discussing this graph of STIs. And we were talking about herpes simplex virus type 2. And we were talking about complications, and first and foremost, that there is no cure. It's a latent disease and it cycles between latent dormancy and then exacerbation. We treat the woman for symptoms. It is a transmittable disease to both her partners and any babies that are born with active outbreaks. The choice, because there's no cure, it's managed with antivirals, typically acyclovir or valciclovir, primarily to just reduce the course of the outbreak and shorten the duration. It could be possibly used in the pregnant client at 36 weeks prophylactically to prevent any outbreaks before birth. And if the woman's had recent outbreaks, she would require a C-section. The latest literature, and this is a change to, I think, even your Flag and Piliteri textbook, the latest literature is saying that originally the literature said no deliveries if there was any active outbreak during pregnancy at all, even if it was more than 4 weeks resolved. The latest literature is saying if it's an early outbreak of HSV and it's resolved prior to 4 weeks before, then the woman could have a vaginal delivery with prophylactic treatment. So it's a slight change. Gonorrhea is your next one. Again, usually asymptomatic. Lots of women don't know they even are carrying the disease. This is characterized by a yellow to gray discharge, accompanied with some vaginal discomfort and perhaps some vaginal bleeding. It is transmittable to both partners and a baby, and it can lead to infertility. And gonorrhea can also become systemic, which is a little bit different than chlamydia. It's rare, but there is a systemic condition that can coexist with gonorrhea. So it's important that it is identified because it can be treated with an injection of 250 milligrams of ceftriaxone. Oftentimes, because gonorrhea and chlamydia tend to coexist, it's not unusual that if a woman has one, she's going to test positive for the other. So in the case of gonorrhea, they'll often treat also with a course of azithromycin or doxycycline to cover her for a chlamydial outbreak as well. HIV is also considered an STI. Now, HIV is covered in your 212 because it has really extensive pathophysiology, talking about CD4 counts, and there's very clear 4 stages of the disease. So it's, for all intents and purposes, we're absolutely going to classify it as an STI. We know that that's one of the main ways it can be transmitted, although it is a blood-borne disease, so it can be transmitted by needle stick, needle sharing, and other ways as well. So I'm not going to get into the pathophysiology, but I will share with you that it's typically asymptomatic when it's contracted, because oftentimes it can take years to know that somebody has contracted HIV. It is CDC reportable. And as far as management and treatment, I'm going to save that for your 212 lecture. HPV, we've talked a little bit about today. That's human papillomavirus. Oftentimes characterized by genital warts, itching, burning, and then obviously those abnormal pap findings. Big complication, you already know this, is the increased risk of developing cervical cancers, and we know that it is transmittable to both partner and babies. Gardasil is the drug of choice, prophylactically given to hopefully kids between the ages of 11 and 12. To start their first of 3-dose series. They'll get a dose, 2 months later they'll get another dose, and 6 months later they'll get another dose. So it's 3 series, a lot like your Hep B series. And we can start that series on people all the way up to the age of 26. For management of the warts, sometimes they'll use different combinations of different acids to burn the warts away. PID, pelvic inflammatory disease, although it's really more of a condition, not necessarily an STI, it is STIs that lead to this, and we know that there's usually swabbed, the pelvic area can be swabbed and we can find bacteria that's related to STIs. It's characterized by pain, pain in the lower abdomen, oftentimes odor coming from the vagina, fevers, chills. Women who progress to PID because secondary to STIs are quite uncomfortable. We know that the complication, or one of the complications, can be the development of ectopic pregnancy, and then we already talked about the infertility issue. And the course of management is going to be antibiotic therapy. And then finally, syphilis. And syphilis is a reportable disease to CDC, and it's categorized or broken down into 3 stages: stage 1, stage 2, and then what we call late. Stage 1 is like that early, if it's caught in stage 1, it's early, the signs are kind of insidious. And then stage 2 can be later, where you start to see pretty classic signs of sores and rashes that can then break out. It becomes more systemic, so you start to see the rash spread on the body. In the late stage 3, you actually would have neuro changes. The complications of syphilis, one of them can be death. You can die from syphilis, and it's a terrible death. It doesn't happen often today because this country did a great job of reporting, tracking, and treating syphilis, although syphilis cases are slightly up in the nation. So it is still reportable, and we look to those different stages. If someone does get diagnosed in the late stage of syphilis, it isn't unusual that they develop cardiac complications. They can go blind and have really a pretty nasty course. Treatment of choice is penicillin G for syphilis. So those are your STIs that you'll want to know. From STIs, female disorders, we're moving on to some of the female cancers. Now, in your previous chapters, when we talked about the genitourinary, you are not responsible for any of your bladder cancers or genitourinary from that chapter. From this particular, we're talking about specific female disorders. These are the 3 cancers that I will cover with you over the next 5 minutes, with the exception of breast. Breast is covered in depth as part of your 212 cancer lecture series. So these 3 are not covered in 212, therefore we'll cover them right now because you should have gotten your prostate back in 112. So cervical cancer, again, you know, we connect this to the HPV virus as being the largest contributing factor. Some of the other contributing factors for developing cervical cancer would be multiple partners, STIs, multiple repetitive STIs, immunosuppressions, and cigarette smoking. All of those have been linked to and associated with cervical cancer. Signs and symptoms, actually, many women don't realize that they have a cervical cancer. It's picked up on their pap smear. But if she were to have some signs and symptoms, it might be abnormal bleeding and perhaps some abdominal pain or painful intercourse. But again, abnormal pap is the most common way that a woman would find out that she has cervical cancer. HPV testing oftentimes can confirm that. So management of cervical cancer, and the good news about cervical cancer is if it's caught early, it's very manageable. Some of the procedures can be uncomfortable for women, like coning and the LEEP procedures and the cryosurgeries can be quite uncomfortable. It's a temporary short-term discomfort and has a high cure rate. Cervical cancer does. In advanced cervical cancer, the treatments might require hysterectomy, radiation, or chemotherapy. Some ways that we can prevent cervical cancer in our female population is to delay the initial age of intercourse and delaying intercourse with a partner. So there's lots of statistics that support that because it allows the immune system to acclimate to that partner. Avoiding smoking would reduce the risk, and safe sex practices to prevent the transmission of the HPV. And then I've listed here your Gardasil recommendations, which again begin at age 11 to 12, 3 doses for the prevention of HPV. Moving on to endometrial cancers, which is also known as a uterine cancer. Again, if you look at the rate of uterine cancer and survival rates, it's pretty good because many women are diagnosed early in the disease like any cancers, and you'll learn more about these next semester, but early detection equals survivorship. So endometrial cancer, the classic sign is abnormal vaginal bleeding, which means that it's the woman who's having bleeding between periods, or more often is the postmenopausal woman who's developed vaginal bleeding. And that is something we pay close attention to. Some contributing factors to the development of uterine cancer could be obesity. Women who are anywhere from 10% over their BMI and beyond do have a threefold increased likelihood of developing a uterine cancer. Nulliparity, women who've never had a baby, late menopause, women who go through menopause after 55, we've found that could be a contributing factor. The diagnostics, typically with that bleeding, they'll do an ultrasound and they'll see a section of the uterine wall that looks a little thick. So they'll go in and do an endometrial scope, and they'll take an endometrial biopsy, and that's how it's diagnosed. The way that endometrial cancer is managed is either typically they can do an implant, a radium implant, although those are not common anymore, and the use of a hysterectomy, surgical procedure, radiation, and possibly chemotherapy if they think that, if the medical team sees that there's any articulation with means to spread. Of course, we offer supportive care, psychological support for the woman. This is, after all, a cancer diagnosis, and all of the pre and post-op instructions that would be given for a hysterectomy, which would go right alongside what you learned last semester for pre and post-op instructions, like turning, coughing, deep breathing, ambulation, prevention of complications of surgery. And then the last female cancer we'll discuss is the ovarian cancer. And ovarian cancer is typically, unlike the other two, does not have as favorable an outlook because there really are no early signs and symptoms. It is not unusual that when this cancer is growing, it's found in a later stage because there's very little early signs, and that's why I have a really sad face on my slide presentation. So some of the contributing factors for ovarian cancer, we tend to see it in women who are over 40, nulliparity, never having children, or if there's a family history of ovarian, breast, or colon cancer. Any of those three, especially in first-degree relatives, we're going to pay close attention and offer surveillance for ovarian cancer. Women who have a history of dysmenorrhea, so those really bad menses that they had when they were young women. Women who've received hormone replacement therapy, HRT or HT. Women who are on infertility meds. These are all the contributing factors. We tend to see slightly increased risks of ovarian cancer in these populations. The manifestations of ovarian cancer, again, no early ones. The late symptoms might be, and again, typically when we find it, she's already late staged, might be pressure or pain in her legs, lower back, or abdomen. She may develop a swollen, bloated abdomen. She feels like she's putting on weight, or jeans feel tight. Indigestion, stomach changes, changes in her bowel movement, fatigue, shortness of breath, weight loss. She feels like her jeans are tight, but she's losing weight everywhere else. The diagnostics that would be used would be the CA-125, and that's a marker. It's an antigen marker in the blood, and if her results are greater than 35, that's considered abnormal. A footnote to CA-125. CA-125 is used as a marker for more than just ovarian cancer, and like those cancers that we talked about above that are contributing factors, it's not unusual that they'll use the CA-125 also in managing late-stage breast cancers as well, in tracking that number, which gives us kind of an idea that there's some embryonic cancer activity happening in the body. So there's neogenesis, we call that. She may have an intravaginal ultrasound to look at her ovaries and a pelvic exam. And basically, ovarian cancer is managed by surgery, removing the ovaries, and oophorectomy, oftentimes done with a uterus, removal of the uterus, which is a hysterectomy. Chemotherapy and radiation also may be offered. I'm going to stop here and go to the next section.